So good evening, everybody. Welcome to our first edition of Conversations with a Doc, a MAPS sponsored program. It looks like we have over 60 people joining us so far, and perhaps a lot more to come too. So for those of you who don't know me, my name is Joe Savitt. I'm one of the movement disorder Parkinson's specialists at the University of Maryland. And I welcome you to, again, our inaugural event, Conversations with a Doc. Just a couple of housekeeping things. We are going to have a brief presentation by our guest speaker. And if you have any particular questions, you can use the Q&A function at the bottom of the Zoom and type your question in, and we'll go through them. And hopefully there'll be a point of discussion for the latter part of the presentation today. There's also going to be a survey that will be emailed to you at the end of the talk, and we really hope that people will fill that out to make sure that even the next session is even more spectacular than this one's going to be. I also just want to briefly thank our sponsors. There'll be a slide that talks about who they are at the end of the talk as well. And thankfully for their generous support, we're able to do this at no cost to anybody. So that part's really good. So without further ado, I'm going to introduce our guest conversationalist, Dr. Hamadani. He comes to us from Philadelphia at the University of Pennsylvania. He actually did his medical training here in Maryland at the University of Maryland. I guess also got a public health degree at Hopkins at Bloomberg, I think. Went on to do internship and residency at Penn and stayed on for fellowship and faculty. He's done really interesting work in looking at the connection between Parkinson's disease and changes in vision and how it affects quality of life. So I'm really looking forward to the talk, and I'm going to turn it over to him. And then if you have any questions during the talk, you can type them into that Q&A section and we'll review them. I have some questions that people sent in already, so we have plenty to talk about at the end. All right, so welcome, Dr. Hamadani.
Okay, thank you, Dr. Savitt, and thank you all for being here. It's a pleasure and a privilege to speak to you with you. I'm going to share my screen now. Oh, it says the host has disabled screen sharing. Maybe Andy will help us with that in just a second. But while that's happening, let me tell you a little bit more about what I'm going to be chatting about for just a second. As Dr. Savitt mentioned, I'm a neurologist, but my particular subspecialty, my primary one, is neuro-ophthalmology. And you may not have seen or heard of a neuro-ophthalmologist before. So, but essentially what that is it's a physician who specializes in visual symptoms from neurologic disease, and that includes Parkinson's. And so a neuro-ophthalmologist is a doctor, either a neurologist like myself or an ophthalmologist who kind of focuses their attention on vision in relation to neurologic disease. And it looks like we're able to share a screen now. Thank you, Andy. Okay. So that's who I am. I also have a little bit of a movement disorders practice too, like Dr. Savitt. So I do see some Parkinson's patients for kind of all of their neurologic symptoms, not just visual, but my primary focus is on vision and Parkinson's. So I want to begin, before talking about vision and Parkinson's specifically, about vision and general health, which also includes PD. And because I think to a certain extent, the way that vision is affected in PD and the way PD affects vision is kind of a microcosm of how vision affects us in general as human beings. And just because someone has Parkinson's doesn't mean that all of the rest of the rules about life stop applying. So vision is our most dominant sense. It's what we use to navigate the world around us. And about 40 to 50% of our brain is devoted in some capacity to vision. And when you think about reading, about street signs, about even nonverbal communication, someone's facial expressions, people's body language, all of that eventually is internalized in the form of vision. And as I mentioned, vision's integral to many daily activities: reading, writing, driving, kind of you name it. And I would argue that vision is becoming increasingly important as technology is playing a greater and greater roles in our lives. So for example, people are using text and email more than they are talking on the phone. And as a result, something that didn't involve vision that much, essentially you just needed to dial the number, now involves vision to a greater degree because you're also typing and reading and that sort of thing. We also know that visual impairment is associated with poor health outcomes in the general population, regardless of whether people have Parkinson's or not. Specifically, people who have difficulty with vision are more likely to have falls and become injured, such as a hip fracture. They're more likely to have depression or anxiety. And there's even the suggestion that people with visual impairment are at greater risk for cognitive impairment and dementia. And there's all sorts of theories about why that might be, whether it's because of decreased social engagement because of visual impairment, or kind of a sensory deprivation, if you will, that the brain is not as stimulated as a result of visual impairment. So things that we don't fully know all the answers to. But visual impairment is bad, to kind of put it simply. And what's also important to know is that at least half of all visual impairment in the United States is caused by eye diseases that are preventable or treatable. And these include things that are as simple as refractive error, which is just the name for when you need glasses to see clearly, as well as some common age-related eye diseases such as cataracts, glaucoma, and macular degeneration. And because these are associated with age, and Parkinson's is also associated with age, these kind of cluster together pretty frequently. And as a result, it's important to see an eye doctor regularly, regardless of PD. So having said that, now we'll move into sort of some specific PD-related aspects of vision. So some general thoughts. Number one is that vision is affected in PD. And this is something that perhaps wasn't recognized when Parkinson's was first described, but now I think is something that people are realizing more and more. But it's also important to know that Parkinson's can affect vision in a number of different ways, and the experience is different for everyone. So just because there's a paper or a book or a person who says that Parkinson's affects vision in this way or that way, doesn't mean that that's how it affects you. It might be affecting you in a different way. Or some people may not notice much trouble with vision from Parkinson's at all, and that's great. So it's a highly individualized and unpredictable experience, much as I can imagine other symptoms of Parkinson's are. These symptoms of vision that are Parkinson's related can negatively impact quality of life, but they generally do not result in loss of vision. By loss of vision, I mean reduced visual acuity, like the way we measure vision on charts, 20/30, 20/40, 20/50, that sort of thing. In other words, Parkinson's does not cause blindness. So occasionally patients will ask me, is Parkinson's going to cause me to go blind? And the answer is no. But that doesn't mean that the difficulty with vision that Parkinson's causes is benign or is not a big deal. It can still affect people quite significantly. The good news is that many of the visual symptoms of Parkinson's are treatable. And kind of for better or worse, those treatments are not typically consisting of adjusting Parkinson's medication. So most visual symptoms in Parkinson's are treated with things other than medication. This could include adjusting your glasses prescription in a certain way, eye drops for dry eye, and other kind of lifestyle modifications. And as I mentioned earlier, there are many other things that can affect vision besides Parkinson's. Many of those things accumulate with age, as does Parkinson's. So as a result, it can be difficult to tell whether someone's symptoms are from Parkinson's based on just their description alone. Or in other words, visual symptoms such as blurry vision or I'm having difficulty seeing are inherently kind of vague and could be due to many different things. And so this is why it's important for you to see a doctor to try and distinguish between Parkinson's and non-Parkinson's related causes of difficulty with vision, because those are things that are treated very differently. So some common visual symptoms of Parkinson's that I'm going to touch on today. One is dry eye. We'll also talk about double vision, difficulty with reading, impaired depth perception, and visual hallucinations. And there's room for many others to talk about, and hopefully we'll have some good questions to trigger some good discussion too. So dry eye is probably the most common visual symptom of Parkinson's. And I like to explain this by beginning with a very silly question, which is why do we blink? Everyone who's awake is blinking 10, 15 times a minute. And the reason we blink is to keep the surface of the eye moist. Because if we did not, the cornea, which is the front of the eye, would become dry. And that would cause it to not see well and could even cause some scarring and some very serious damage too. So that's why we blink. And in Parkinson's, people's blink rate, or the number of times per minute they blink, is decreased. And therefore, they are prone to developing dry eye. In addition, there are some Parkinson's medications that can worsen dry eye. And these are medications that have what we call anticholinergic properties, such as amantadine. And then a related concept to dry eye is a condition called blepharitis, which is some irritation and inflammation of the eyelids. And that often goes hand in hand with dry eye and can produce similar symptoms. Those symptoms of dry eye include kind of what you might think of as typical dryness, but I think it's important to realize that they do affect vision in a pretty significant way. So blurring of vision, glare, sensitivity of light, those could definitely be symptoms of dry eye. As I said, an actual feeling of dryness or irritations, which at times can be quite painful. So some people might describe dry eye as soreness, aching, stinging, that sort of thing. And then there can also be a component of itching, redness, a foreign body sensation, which means that it feels like there's sand or paper in someone's eye. And then a really important symptom of dry eye that is somewhat counterintuitive, which is why I'm emphasizing it here, is that watering or tearing of the eyes can also be a sign of dry eye. And that might seem like it doesn't make sense, because if you're watering and tearing, then that means that there's too much moisture. How could they possibly be dry? And it turns out what's going on is that when you have dry eye, your body reacts to that dryness by producing extra tears. But those tears are not the right type of tears, which means they don't actually lubricate the eye the way they're supposed to. And so you end up in this paradoxical scenario in which your eyes are dry, yet you experience it as watering or tearing. So I always emphasize that because that's a very common symptom of dry eye, but one that seems kind of counterintuitive. And like I said, some people can have some of these symptoms and not others. And some may actually not have any symptoms at all. So I see many Parkinson's patients who tell me, my eye doctor told me that I have dry eye, but I don't really think that my eyes are dry, or I don't really feel like they're dry. And that's certainly true. Much of dry eye can be asymptomatic, but I do still think that it's worth addressing and treating, because like I was saying earlier, down the road, those can lead to some permanent difficulties with vision, scratching and scarring of the cornea and such. So even when dry eye is asymptomatic, it is still something that's important to note. So the treatment of dry eye consists of a few different things. One is that you might ask yourself, if the problem in Parkinson's vis-a-vis dry eye is that patients do not blink enough, then maybe we should try to blink more often. And I welcome anyone's efforts to do that, but I have to say, I think that's something that's very hard to do. Something that's automatic and we don't think about is hard to then think about and be conscious about. And especially for something that happens so frequently, 10, 15 times a minute. So sometimes patients are told to try and blink more often, but I think that's something that's pretty hard to do, kind of like controlling how quickly or slowly you breathe. One thing I will say, though, is that the blink rate naturally increases with stimulation or activity. So when you're up and about and moving, when you are exercising, when you're having a conversation, when you're doing these things, when you're gesturing with your hands like I do when I talk, you end up blinking more often. And so indirectly, that might end up moistening the eyes more. And then conversely, we blink less when we are staring or reading things, basically, especially screens. So I think it's important to realize, if you're someone who enjoys reading, that might be something that is kind of related to dry eye, because you may not be blinking as much. And then you might consider, every few pages, pausing, putting the book down for a moment, going to get up, stretch your legs, get a glass of water or something, and then getting back to it. That may contribute to a little bit less dryness and strain. That being said, though, the mainstay of treatment for dry eye in Parkinson's is artificial tears. These are available over the counter, so you do not need a prescription for them. And I don't endorse any one particular brand or anything. There are many to choose from. But the important thing is that they say that they are preservative-free, because eye drops that have preservatives in them can cause more irritation and greater dry eye problems in the long term. So specifically, you should avoid any eye drop that purports to get redness out or reduce redness, redness relief, get the red out. Avoid all of those things, because those contain preservatives. So just make sure that the bottle says preservative-free artificial tears, and then you should be good to go. You might notice, if you go to buy artificial tears at the pharmacy, that there are kind of daytime and nighttime preparations. So there might be a regular daytime one, and then it'll say like artificial tears PM, or nighttime or something like that. The main distinction is that the nighttime one is a little bit thicker, and that's because our eyes tend to dry out the most at night. because we don't blink, while we're sleeping because our eyes are closed. So having both daytime and nighttime ones can be helpful, using the nighttime one at night for greater relief of dryness, like I said. The one kind of caveat, though, is that the nighttime one, because it's thicker, does blur your vision a little bit when you put it in. So it's not one that you'd want to use during the day, and might need to be a little bit mindful if you put it in at night and then are someone who has to get up in the middle of the night to go to the bathroom. Just make sure that that's not blurring you out too much when you do wake up in the middle of the night. You can use artificial tears up to 4 to 6 times a day. So essentially, there's no such thing as too much. And because it's something that's easy to forget, and people with Parkinson's have so much on their plates already, what I generally recommend is to consider timing artificial tears with doses of carbidopa, levodopa, or other medications. And that way, you won't forget as much because they're kind of part of your routine, with other things. I included some brands here. Just people often ask me what's the name of one I can look for. But like I said, I'm not endorsing any one of these in particular. And then I mentioned earlier, there's a condition called blepharitis, which is irritation or inflammation of the eyelids, and is kind of related to dry eye. That's treated with something called warm compresses. And so the way that works is you take a clean washcloth or paper towel, soak it in warm water and wring the excess water out. And then you'll close your eyes and place the towel over your eyelids. Keep your eyes closed for the next 5 to 10 minutes. And then you could take it off and then gently wipe your eyelids. And what that does is it loosens up some of the oils that the skin and the eyelids naturally produce, and helps to kind of clear up some of that buildup, which will cause less irritation and dry eye over time. And then if none of these work, then you should follow up with your eye doctor, because there are some prescription eye drops for dry eye, and occasionally there are even some procedures that can be done to treat or reduce dryness. So there are many, many options for it. All right, next I'll talk about double vision. As I've kind of illustrated here, what I mean by double vision is seeing 2 of the same object instead of just 1. So not necessarily blurring alone, but actually seeing 2 of them. And double vision in general can occur for 2 different reasons. And I'm talking very generally here, so not just Parkinson's. One is that there can be a problem in the front of the eye, such as needing glasses or having dry eye. That is double vision that persists even when you cover one eye, and is not particularly related to Parkinson's. But the other type of double vision is the one in which each eye is individually healthy and sees well, but the 2 eyes are pointed in slightly different directions or misaligned. And therefore, each eye is seeing something a little bit different, and that registers as double vision. And when this is the case, the double vision gets better or resolves when one eye is covered, and it does not matter which eye. And this is the type of double vision that's potentially related to Parkinson's. So if you have double vision and you're not sure, could this potentially be related to Parkinson's or not, you can just simply try this. Try covering one eye or the other and see if it goes away. Double vision is common in Parkinson's, and it's more common than we might think or that we previously thought. There are some studies suggesting up to 20% of people with Parkinson's have double vision. And the most common pattern of double vision is one that's present primarily at near. When I mean at near, I mean looking at something up close, like when you're reading, but is not occurring as much at distance. And that's something called convergence insufficiency. The other kind of scenario to keep in mind with double vision is in the immediate period after deep brain stimulation, because sometimes, particularly with one of the DBS targets, it's actually located in a part of the brain that's pretty close to the eye movement centers of the brain. So sometimes the surgery or stimulation settings, during deep brain stimulation can induce some double vision. The main treatment for double vision in Parkinson's are to get something called eyeglasses with prisms. Prisms are a type of eyeglass. They look just like regular glasses, and they can also correct for your nearsightedness or farsightedness like regular glasses do. But in addition, they correct for double vision. Not everyone enjoys prisms, though, and it kind of depends on how much double vision bothers you and kind of how it fits in or kind of how it affects your life. Alternatives would be to wear an eye patch as needed. There's nothing wrong with that. Wearing an eye patch is kind of similar to covering one eye or the other, like I was talking about earlier. So if the problem is that the eyes are misaligned and looking in different directions. And that's why you're seeing two images that are slightly different. If you cover one eye, you remove one of those images, and so you'll no longer have double vision. Wearing the eye patch is kind of entirely for your relief. It doesn't strengthen or weaken the eyes. And it also does not matter which eye you cover. You can do either one. And for people who don't necessarily like the look of an eye patch, an alternative would be if you wear glasses, you can put Scotch tape on one of the lenses of your glasses, and it will blur the image a little bit so you don't see double anymore. I get a lot of questions about eye muscle exercises in Parkinson's, and unfortunately, eye muscle exercises have not really been shown to be helpful for double vision in general. It's not really been studied specifically in Parkinson's, but the few studies that have been done in other double vision patient populations have shown that for most people, it does not really work that well. For convergence insufficiency, sometimes it can, usually after a concussion. And I think the reason is that the eye muscles are fundamentally different from the other muscles in our body in the sense that they are always working all the time. And so there's really not a way to strengthen them any more than they're already working. Right now, as I'm looking at my computer screen and reading the text on the slide, all of 6 of my eye muscles on each side are working. And if you're looking at the screen, all 6 of yours are doing the same thing. So it's unfortunately not really possible to strengthen them or work them in, any more than we already do in our daily life. Double vision and dry eye can affect a lot of visual tasks, such as reading, but difficulty reading is common in Parkinson's, really even beyond these 2 symptoms alone. And this is because reading is actually a pretty complex and demanding task from a kind of vision and neurologic perspective. So first, in order to read, you need to have clear vision, especially up close, because most of what we read is on books and magazines and screens that are within a foot or 2 of us. And then also what happens when we read is our eyes move very quickly from one word to the next. And you don't realize this when you're reading because you don't really feel your eyes move in that way. But if you ever watch someone else reading, if you pay close attention, you'll see their eyes darting all over the place. And so that's something that we take for granted and we don't think about at all, but it's actually really important for reading, and especially for reading kind of fluidly and at a pace that we like, is for the eyes to quickly move from one target to the other. And anything that affects vision, including dry eye or double vision, like I talked about earlier, will disproportionately affect reading the most because reading is, I guess, one of the more visually demanding tasks that we do. I think a general rule of thumb, again, regardless of PD, is that everyone starts needing reading glasses after about age 40 or 45. And that's a normal aging process. Basically, the lens in our eye does not adjust as easily to near over time. Some people use what are called bifocal or progressive lenses. And so what that means is that there are actually 2 different prescriptions in your glasses. There's one that is this large part at the top, which is labeled as distance in this picture here. And then there's actually another prescription in this smaller area, which is for reading or looking up close. And progressives are the same thing, but the line is blurred, so it doesn't show up as a line. But the important thing to realize is that bifocals and progressives limit the amount of space you can look through to read. So essentially, when you read, you're only using this small area of the lens which says near. And we know that people with Parkinson's can have difficulty generating quick and accurate eye movements, moving from one word to the next, especially within such a small space. So for difficulty reading in the setting of Parkinson's, many people benefit from having separate glasses for distance and separate glasses for reading, rather than using bifocals or progressives. If bifocals or progressives are something that works for you, then that's great. There's no harm to using them. But when people come to see me who have Parkinson's and difficulty reading is a big problem, that's usually the first thing that I end up recommending to them. Next, I'll talk about depth perception, which is a common complaint that I hear from people with Parkinson's. And what depth perception means is the ability to perceive 3-dimensional space. In other words, each eye only sees a 2-dimensional flat object. But what happens is our brain there are parts of the brain that can tell that each eye is seeing a different side of things. And then they use that to create a 3-dimensional kind of map of the space around you in your brain. And depth perception can be affected in Parkinson's for a couple of different reasons. Number one is that in order to have good depth perception, you need to have good vision in each eye. So any difficulty with vision, whether it's cataracts or macular degeneration or really bad dry eye or anything that's causing you to not see well will by definition affect depth perception too. Second, in order to have good depth perception, your eyes need to be pointed at the same target. In other words, you should not have any double vision. And so occasionally, double vision, which I had talked about earlier, can also affect depth perception. Actually, it's pretty common. And then the last thing that needs to happen in order to have depth perception is that parts of the brain, like I was saying earlier, need to kind of combine the images that each eye is seeing in order to perceive depth. But basically, the parts of the brain that orient you to space need to work. And that's probably where most of the difficulty with depth perception in Parkinson's comes from. Some people, like when I say depth perception, that means kind of different things to different people. So let me give you some examples about how you might notice difficulty with depth perception or how that might affect someone. So one is reaching for objects. Every time we reach for something, we, in our minds, have to judge how far away it is so that we know how far to reach. And if you misjudge that, then what you might find is you reach and you don't reach far enough. Or you're reaching and you're kind of reaching to the side or reaching too far. A story that patients often tell me is of people with Parkinson's frequently putting objects at the edge of the table. So someone might have put this cup and saucer on the table and think that it was actually further back in the middle of the table, but it's actually teetering here on the edge and is at risk of falling. Driving or parking is another scenario in which depth perception is important. Every time you drive or park, you have to know how far away your car is from the car next to you so that you don't hit it. And so particularly parallel parking or parking in tight spaces can be challenging. If you're uncertain if you're how close you are to the car next to it, you might be nervous about hitting it. And then as a result, sometimes patients end up compensating by relying on extra distance. So I've heard some patients say that they maintain a lot of distance from the car next to them when they're driving just because they're not exactly sure of how far away it is, so they want to be safe. A motor symptom of Parkinson's is something called freezing, which is a tendency for one's feet to get stuck or have difficulty initiating steps. It's not a visual symptom per se, but I mention it because there's a tendency for freezing to occur in certain spatial environments, specifically in doorways or narrow hallways or other kind of tight spaces. And we don't know exactly why that is, but we think that the parts of our brain that judge the space around us and tell us how far or how close we are to something are connected in some way to the movement generating centers of our brain. And so misjudging that distance kind of subconsciously is kind of indirectly involved in the phenomenon of freezing. I mentioned driving earlier in the context of depth perception, so let me talk about that a little bit more. Driving is a very complex task, and it involves a number of different modalities, only one of which is vision. So things like attention, coordination, reaction time are also important in driving. And so for that reason, Parkinson's-related visual symptoms like depth perception can affect driving, but when that's the case, usually they can be kind of managed with caution. So I mentioned maintaining extra space between yourself and the car next to you just to be safe. Many patients with Parkinson's do have to stop driving at some point, but this is usually for reasons other than vision, for things like cognition or multitasking and that sort of thing. So a question I get a lot is, my vision's like this, can I drive or not? And usually what I kind of explain this and explain that vision definitely is affected in people with Parkinson's and affects you in many ways, and driving might be one of them, but ultimately the decision of whether to drive or not is usually driven by some other symptoms and not necessarily by vision. Visual hallucinations are something that you might not think of as a visual symptom, but I do because it has to do with vision. It's simply just seeing something that is not there. And this is very common in Parkinson's. Half of patients with Parkinson's will experience it at some point in their lives. And one thing we know is that it is wildly underreported in practice. And that's for several reasons. One is that as doctors, we're not as good as we should be about asking about it. And also, patients and their families might be afraid of being perceived as crazy, or that hallucinations are a sign of dementia or something like that. But in fact, it doesn't necessarily have to be either of those things. And of course, no one is crazy. I mean, that's not a word that we really use anyway. Um, Hallucinations are a direct manifestation of Parkinson's, and they can also appear or worsen with certain medications too. Hallucinations can cause a wide range of symptoms. Sometimes in the beginning, it might not be that you actually see something like a clear image of something that isn't there. It might be just a feeling of someone or something standing or being next to you. But then you look and you see that nothing is there. Or sometimes there's a vague sense that something is moving off to your side, like something past you. Then you look and you see that nothing is there. As kind of symptoms progress, people will describe a more kind of clearer picture of a shadow or a shape that passes by. And then over time, that shadow or shape may become more and more detailed. It may look like an animal, a cat, or children, neighbors, that sort of thing. And sometimes it can be quite distressing, seeing images of people outside who are trying to break into the house or something like that. And these are very kind of distressing and disabling symptom, but there's absolutely no shame in them by any means. Treatment for hallucinations consists of adjusting Parkinson's medication. Sometimes some of the medications that we give to treat tremor and slowness of movement can worsen hallucinations. And there are some medications that can be used to treat hallucinations specifically as well. One kind of question that we don't fully know the answer to, but I just want to kind of put out there, is the question of how is our visual function related to hallucinations, or is poor vision a risk factor for hallucinations? And the reason that we think that it is that there is a balance in our brains between visual information that comes from the outside world, things that we see around us, and information that is stored inside our brain, like the images from previous memories or dreams. And the thought is that hallucinations represent an imbalance between images of the outside world and internal images from memories and dreams. And that could be because there's too much of the internal images, or it might be that there's not enough of external visual stimulation. And there's some evidence to suggest that having good vision, or in other words, clear images of the outside world, is important for suppressing or preventing hallucinations. There are, in fact, some people who actually have vision loss due to severe eye disease, like macular degeneration. And it turns out they can actually have hallucinations just like the ones that happen in Parkinson's, even though they don't have Parkinson's. And some research that we're doing is showing that eye disease, like glaucoma or macular degeneration, can be a risk factor for hallucinations, both in people with Parkinson's and in people who have other conditions too. So I mention that just as a kind of way to tie in our eye health and how well we see with hallucinations, and then kind of taking good care of one's vision, going to the eye doctor regularly, may have a role to play in reducing or preventing hallucinations too. I just want to touch a little bit on contrast sensitivity or color vision, just because if you search kind of vision and Parkinson's, this might be something that comes up. So contrast acuity or contrast sensitivity refers to how well we see under different degrees of lighting or kind of brightness. And so this is one way that we measure contrast acuity. You can see that at the top row, the letters are very dark and bold. And then as you go down, they kind of fade and become lighter and lighter. And towards the bottom, it might even be difficult to see the letter from the background. And then color vision is, this is kind of how we tested. These are called the Ishihara color plates. And it basically just asks, being able to distinguish one color from another. In this case, we asked, do you see a number in the middle? And the number is 5 that's in green on this reddish orange kind of background. There have been a number of studies that have shown that contrast sensitivity and color vision are reduced in people with Parkinson's compared to people who do not have Parkinson's. But my experience has been that this is largely asymptomatic. And I ask all of my Parkinson's patients about it, and I actually never had anyone tell me that it was something that they noticed or bothered them. And then the other thing I'll say is that, as with anything in vision, of course, other things that can affect it besides Parkinson's, specifically color vision is something that totally separate from Parkinson's can be inherited as sort of an isolated genetic trait, difficulty with color vision. So in fact, about 1 in 30 or 1 in 20 males is actually colorblind. Again, not Parkinson's related. So I just mentioned that in case there's someone out there who's looking at this slide and not seeing a number, does not necessarily mean that you have Parkinson's or that it's Parkinson's related. Let me conclude with a few questions that I get from my Parkinson's patients a lot about vision and Parkinson's. One is that when I take my glasses off, I can't see well, but then when I put my glasses on, I see just fine. Is this related to Parkinson's, or is it a sign of another problem? And the answer is no, that needing glasses is just related to changes in the shape of the front of your eye. Those things increase with age. And so it's normal, if you're someone who wears glasses, to feel over time that you need those glasses more and more. But as long as you see well with glasses, we consider that to be reassuring and not a sign of Parkinson's or any other neurologic condition for that matter. So vision that can be corrected with glasses is by definition reassuring to us. Another question I get often is that my eye doctor told me that I have cataracts or glaucoma or macular degeneration, and is this somehow related to my Parkinson's or not? And the answer is that probably not, but we don't know for sure. The reason that this is so confusing is that those conditions, cataracts, glaucoma, macular degeneration, are all associated with age. And because Parkinson's is also more common with age, they're relatively common in people with Parkinson's. And in addition, the second two conditions that I mentioned there, glaucoma and macular degeneration, are actually neurodegenerative conditions in which cells in the nerve of the eye, basically the optic nerve or the retina, degenerate over time. And Parkinson's disease is also a neurodegenerative condition. So for that reason, there has been the suggestion that there might be some shared risk factors that predispose one person to developing both Parkinson's and also to developing glaucoma. But that being said, the studies to show that glaucoma is really more common in people with Parkinson's than people without Parkinson's have been kind of inconclusive and have yielded conflicting results. So at this time, we don't know for sure that the two are actually related. And then cataracts which represent kind of age-related clouding of the lens in our eye, are correctable with minor surgery. And always important to know that Parkinson's alone is not a disqualification for any of those treatments, including cataract surgery. And if anything, seeing well is as important as ever for someone with Parkinson's, where we want to do everything we can to maximize quality of life, prevent falls and other negative health outcomes. So with that, I'll conclude. This is Pennsylvania Hospital in Philadelphia, which is where our Parkinson's Center is, the oldest hospital in the country. And thank you for your attention, and I'm happy to take any questions.
Yeah, so that was spectacular. Thank you so much. Covered a lot of things. Covered actually a lot of the questions that were submitted already before your talk. So I think your frequently asked questions section probably covered a lot of the frequently asked questions, as you would imagine it would. I guess we've gotten a few questions in our question and answer thing. So I would encourage anyone who has a particular question to submit their questions that way. And I think in the meantime, maybe we'll start looking at some of the ones that we already have. So one that just came in is, are floaters a form of hallucinations? So perhaps you can kind of address that, or maybe talk a bit about what a floater is.
Sure. So floaters are the experience of kind of seeing a small grayish or black kind of dot or shadow pass or float through your field of vision. And technically they are hallucinations in the sense that you're seeing something that is not there. But floaters are a very common thing that happens to people without Parkinson's too. So I wouldn't necessarily lump them in with hallucinations, at least in the context of Parkinson's that we're talking about. The official fancy name, in case you hear, is called entoptic hallucinations, meaning hallucinations but coming from inside the eye. And what's caused by, so that it turns out there's a gel in front of the retina, which is called the vitreous. And over time and with age, that develops little condensations, and those cast a shadow on the eye. So that's why you see them. Sometimes in the very beginning, hallucinations in Parkinson's can, because they're kind of vague shadows, sometimes they might be similar to floaters, or in fact, sometimes your ophthalmologist might think that they're floaters in the beginning. And I think one thing that's helpful in terms of distinguishing them is the size. So classic floaters are pretty small, kind of the size of a little gnat or fly or something like that. But if there's a large blob or a shape, and especially if it has, if like it resembles something to you, if it looks like the shadow of a person or something, that might be a clue that it's more than just a vitreous floater. Um, yeah.
Yeah, very good. Yeah, I remember when I was in medical school, I was taught if you get a floater, all you can do is name it because it's going to be with you forever. I guess there are ways to get rid of them these days, but yeah, they're common and certainly not really specific to Parkinson's. And yeah, excellent. So let's see, we have another question. I'm just going to read them. So can you talk about photophobia and also involuntary eye closing?
Yeah, that's a great question, which is normally part of my slides, but I wasn't sure if we'd have time for it. So photophobia means sensitivity to bright light. And specifically, it means kind of discomfort provoked by bright light. And that's different from people who have like eye pain or tearing from bright light. That could be from scratching your eye or something like that. But a sensation that bright light causes you discomfort or that you can't stand it is what photophobia refers to. And in the context of Parkinson's, that can be a couple of things. One is that there is a movement disorder which is called blepharospasm, which refers to involuntary eye closure. And that's typically characterized by increased blinking and kind of squeezing of the eyes. And it can sometimes occur in Parkinson's, although it can occur in other patient populations too, in PSP, or and actually can even happen in people without Parkinson's or anything like it. And then there is a different type of involuntary eye closure that rarely some patients with Parkinson's get, which is called eyelid opening apraxia. And that refers to difficulty keeping your eyes open. And in contrast to the squeezing of the eyes that people with blepharospasm have, eyelid opening apraxia is kind of the eyes kind of quietly close themselves. They're not squeezing or anything. And then it's kind of effortful to hold them or keep them open. So those are things that can occur in people with Parkinson's, although frequently occur in other settings as well. Occasionally can be medication responsive in Parkinson's, but usually are not. And they can be treated in other ways as well. Both some botulinum toxin injections for the eyelids and also some non-medication related treatments can help too.
Yeah. Yeah, we're getting a bunch of questions. So there's been a bit of a thread about how vision changes may either come and go with relation to taking Parkinson's medicines. So have you noticed much of a fluctuation with vision and people taking their medicines?
You know, it's not something that I've had many patients tell me about, but I think there could be a couple of things going on that might explain why your vision feels different during an on period than off period, or shortly after taking medication compared to otherwise. One is that I mentioned that people with Parkinson's have a reduced blink rate. That blink rate actually does increase with dopamine and with Parkinson's medication. So it could be that when someone has taken medication and their motor symptoms are better, they're actually blinking more, and maybe their dry eye is a little better during that time too. And then there is actually, so we think of dopamine as something that is in the brain and kind of helps us move and everything like that. But it turns out dopamine is also a neurotransmitter in the retina too, in the back of the eye. And there is some evidence that those things like contrast acuity and color vision that I was telling you about might be a little bit sensitive to dopamine and to those levels. But again, that's one that I think is probably not something people would notice as much. So my guess is that it's primarily driven by the dryness.
Okay, yeah, I think there was a question about, yeah, just kind of feeling the eye sensitivity sometimes when the medicines wear off and squinting. So
yeah, that could potentially be, again, I don't know for one individual, but sometimes like a sensation of sensitivity to light and squinting that comes on as your medication wears off, that could actually maybe be a sign of blepharospasm, but hard to say. I did see one question here about why you might see a neuro-ophthalmologist versus a regular ophthalmologist. And the most common reason that people come to see me is when they have seen their ophthalmologist and either that doctor wasn't able to figure out what was going on or thought that it might be brain or nerve related and they need some help. So usually people are coming to me having already seen their ophthalmologist and are kind of referred by them, or occasionally your neurologist might refer you as well. But in general, like I said, everyone should have a regular eye doctor that they see every year or every other year. I usually kind of start with that. And then if you're not getting what you need from there, then a neuro-ophthalmologist might be a good next step.
Yeah, I guess there was also a kind of a similar question. How do you find a good eye doctor? Do you have any lists, any websites, any advice on how to find a neuro-ophthalmologist here in the Baltimore, Washington area? We have quite a few actually, so we're pretty fortunate around here, and I refer people to several different places and to several different people. But is there any resource that you're aware of?
So for just good eye doctors in general, I don't know specifically in the Baltimore, Washington area. I always tell people, frankly, that for basic things like getting glasses, dry eye, your annual checkup and everything like that, the best eye doctor is the one that you can get in to see most conveniently, and rather than traveling far and wide for one particular person. One thing that maybe is worth clarifying is the distinction between an ophthalmologist and optometrist. Both are sometimes called eye doctors, but sometimes people aren't totally clear on the distinction. So the difference is that ophthalmologists are physicians. They've done medical school and then they did a residency in ophthalmology, much like Dr. Sabat and I did residencies in neurology. And so they diagnose and treat eye disease. They're also the doctors who perform surgery, like glaucoma surgery, cataract surgery, and things like that. And then optometrists are healthcare providers who have not done medical school, but they go through a separate training path, which is called optometry. And so they are able to diagnose most common eye diseases. They prescribe glasses, but they generally do not manage any eye disease like glaucoma, and they certainly don't do any surgery. So for simple things like a routine checkup, getting glasses, an optometrist is fine. But if there's concern for another eye condition like cataracts or glaucoma, then someone should be seeing an ophthalmologist instead. And because those things tend to become more and more common with age, by about age 65, we think that most people should probably be seeing an ophthalmologist, but that's not a hard and fast rule. So just to kind of clarify what that means.
So there's another question, and it kind of dovetails into another issue I was going to ask about myself. So this question: can you diagnose Parkinson's due to changes in vision even prior to the onset of motor symptoms, or prior to when a person realizes they even have Parkinson's? And I guess my add-on to that is I've understood that there is some research looking into charting progression of Parkinson's, or making a diagnosis based on changes in vision and what the eye looks like, what tears contain, and a variety of things. So when it comes to actually, kind of the reverse, right? So how does vision, making diagnosis of vision changes impact our understanding of Parkinson's?
Yeah, so that's a great question, and one that is the subject of a lot of ongoing research right now, but that research has not kind of finished yet, which means that currently we can't really use the eye exam in a specific way to diagnose Parkinson's or monitor it. But just to give you a sense of what people have been interested in looking at, so in Parkinson's, there is a protein that is called alpha-synuclein that accumulates in certain parts of the brain and that leads to the motor symptoms of Parkinson's. And there's been some interest in looking for alpha-synuclein in the back of the eye, which is called the retina. And the reason that would be appealing is that we can't easily look inside the brain. I mean, we have MRIs and stuff that are time-consuming and challenging and don't always give us the picture we want. But you can dilate someone's eyes and look very easily in the back of the eye. And so there have been some efforts to try and non-invasively image alpha-synuclein in the retina. Unfortunately, those have not been as successful as we'd like. And then I think Dr. Sabat had mentioned tears, so you can measure the protein levels in tears. There is a retinal imaging technique that we actually use quite frequently in practice for other eye conditions that lets us measure the thickness of the retina. And there have been some studies showing that the retina is a little bit thinner in people with Parkinson's than in people without Parkinson's. But the challenge, and the reason that's not really used as a diagnostic tool, is that that difference is very, very small, which means that you can't easily draw a single cutoff and distinguish normal from abnormal in that way. In fact, most people with Parkinson's if you do that test, would show up perfectly normal. So it's something that can be an indicator of degeneration and is, I think, useful potentially in the research setting, but not something that we can make any diagnosis by. As far as distinguishing Parkinson's from other things, so I saw there was a question about someone who, with Parkinson's, who was later diagnosed with PSP. There are some eye movement features that help us to distinguish typical from atypical forms of Parkinson's. And those are things that we do in clinical practice to help make that distinction. And that doesn't require any special equipment or anything.
It looks like there's some questions about more specific ways to treat hallucinations. So which medications are available and what are their side effects?
Yeah, so I can talk about that a little bit. Maybe Dr. Sabat, you might want to take part of that too. So there are a couple of medications that have been used to treat hallucinations in Parkinson's, one of which was FDA approved several years ago. And the way they work is by blocking certain receptors in the brain that we think are involved in hallucinations. The decision of when to begin one or not is an individual one. It kind of depends on how severe the hallucinations are, and do they outweigh the potential risks of those medications. So I think common side effects are drowsiness, sleepiness, and kind of things like that. And then depending on what other medications you're on, sometimes we need to be mindful of your heart rhythm or other kind of things like that. But I don't know, Dr. Sabat, anything you want to add to that?
Yeah, no, I think, no, that's perfect. I think when I think about it, there's certain medicines that we use to treat Parkinson's that seem to put people at a greater risk for developing hallucinations. And so we talk about dopamine agonists or amantadine, and you kind of weigh the positives and the negatives based on those medications. How much benefit are you really getting by a particular Parkinson's medicine? And we taper those back. And generally, I think most people shoot for being just on levodopa. I found occasionally some of the medicines that we use for thinking and memory, things that are generally used more for Alzheimer's than for Parkinson's, but I've had certainly patients who at least tell me their hallucinations are improved, or perhaps they kind of know that they're not real a little bit more easily when they're on these medicines. And so there's several of those. And then the specific ones, there's quetiapine and pimavanserin are used. And then Clozaril, which is an old medicine, which is really good at blocking down hallucinations in my experience. It's just been difficult because you have to get blood tests very frequently. And the people who are making it are actually trying to figure out a way to make the blood tests a little bit easier, maybe things that can be done remotely. So it can be a challenge, and these things can be scary, and they certainly are underreported. I think people are a little bit shy about talking about them. But I always ask, I have a list of questions, and that's always one that I ask, because sometimes even though they're friendly, the hallucinations oftentimes are people. We always worry that they're going to turn on you and become scary. So these are good questions. I often get an EKG, so a heart tracing to find out the different intervals. There's one spacing in the signal that you get when you check a heart rhythm, that if it's too long can be a little bit dangerous to start these medicines. And so I'm a big believer in getting a lot of heart tests for those. But generally they can be very effective. And it looks like there is the question, is Nuplazid the new drug referred to for hallucinations? And yeah. It's also known as pimavanserin. So that is the new one. So let's see, is there much else? Oh, yeah. Trying to get the hang of looking at all these questions. And do swings in blood pressure affect vision? Do hot flashes affect vision?
So for swings in blood pressure, I suppose they could. Usually the way that would present is when people who have dizziness and low blood pressure upon standing. So when you stand suddenly, you might feel lightheaded and dizzy. And when that happens, people might feel like their vision is kind of blacking or spotty or that sort of thing. Usually just lasts a few seconds. And that's because when your blood pressure drops when you stand, your eyes for just a few seconds are not getting enough blood, and so that's what causes them to darken a little bit. Um, and that's, as an aside, the same reason that you feel dizzy or lightheaded when you stand is your brain is not getting as much blood from the drop in blood pressure. But again, just for a few seconds and not something too harmful. As far as hot flashes, probably not, or not in any specific way. But I think it's just a general rule of thumb is that whenever someone is uncomfortable, that frequently translates into some sort of difficulty with vision, even if that difficulty is a little difficult to describe. And I think the best example of that is headache. So anyone who has a headache is in that moment going to feel like something is just not quite right about their vision. And it's not that there's a specific problem in one part or another, but just that I think not feeling well in general frequently translates into some sort of change in vision.
I guess there's a bit of a thread about, as far as having Parkinson's, does that actually put you at risk for other types of eye diseases? I know you touched on that a little bit. Specifically, there's a question about retinal vein or artery occlusions. And I think you did touch on the glaucoma and the cataract issue. But does any other things that you look out for in particular in a Parkinson's patient with regard to other eye diseases?
Not really. No, in fact, retinal artery and vein occlusions are not known to be related to Parkinson's. So those might be due to some other aspect of one's health.
How about the use of plugging the tear ducts to try to help with dry eye?
Yeah, so that was, I mentioned that for dry eye, sometimes there are some in-office procedures. That's one of the ones that I was kind of alluding to. So first of all, it's something an ophthalmologist would do, not a neurologist or neuro-ophthalmologist. So I actually don't know too much about it. But the general principle is that in people with dry eye, one kind of attempt to try and retain tears more would be to keep them from leaving the eye quite so quickly. So basically, whenever what your body does is you produce tears from the lacrimal gland, which is kind of on the upper outer part of the eye. The tears wash over, and then there's a little duct or tube, basically, that takes the tears and empties them out through the nose. And as an aside, that's why you have a runny nose when you cry, is because the tears are washing out that way. So one potential treatment is to narrow or block that tube and allow more of the tears to stay with the eye for longer. So sometimes that's considered when you've tried a lot of different treatments for dry eye that have not worked. And also, I kind of use dry eye as a very general term in a kind of one-size-fits-all approach, but there's actually several different types of dry eye from a kind of very detailed eye-centric kind of point of view. And so sometimes, I guess all that to say that some people might benefit from that procedure, but others do not. And that kind of depends on what's going on with your eyes, which you would need to see an ophthalmologist for.
How about the role of supplements or diet with vision? I guess there's a specific question about saffron. I haven't heard of that one, helping eyes or helping with macular degeneration, or should we all be eating lots more carrots?
So I'm not sure about saffron either. The main context that vitamin supplementation comes up in is not particularly Parkinson's related, but it's for macular degeneration. So there is a vitamin supplement, it's called AREDS, that has been shown to prevent the progression of macular degeneration. So if you see an ophthalmologist and they tell you that you have the beginnings of macular degeneration, they may recommend that you take a vitamin supplement. It's a very specific one, so it's not just a general multivitamin, but it's specifically vitamins A and E and a few others as well. But outside of macular degeneration, no specific supplements that are particularly recommended.
Okay. And I guess, as our time is winding down a bit, I guess one of the things to always look for is, what's on the horizon. I think one of the things that I've found is interesting is there is this, and I'm sure you're way more familiar with it than I am, but this new questionnaire that's kind of been floating around about that really targets the effect of vision change in Parkinson's. And I think it's really raising a lot of awareness. And that's been somewhat exciting. And perhaps will prompt even more research into this field. So that's great. But what do you see are the big things in the future as far as trying to understand Parkinson's or trying to understand the vision changes or treating the vision changes that happen with PD?
Yeah, so I think, Dr. Sabat, awareness really is key, just as you said. I think we're realizing with many non-motor symptoms of Parkinson's that, first of all, they're more than we realized. So it's important to do research to know just how common they really are so that we can be aware of it, but also how important it is to ask specifically. And if you don't ask, then you might not find out. So Dr. Sabat mentioned asking every patient about hallucinations. That way you make sure you're not missing them. And uh, maybe we should be doing something similar for visual symptoms. As far as kind of further research, knowing that things are more common, we might start to do research into how to kind of build treatment into our practice models more clearly. So if we get to a point where we're asking all of our Parkinson's patients about vision, what do we then do with their answers? Do we have them see an ophthalmologist? Does that ophthalmologist know what to do? So kind of building a system around these the symptoms that patients are having is important so that the healthcare system really is working for you. And then we talked kind of briefly a couple of times about glaucoma and macular degeneration, how we're not sure if these are really related to Parkinson's or not. There's more research to be done there. But I think those are also important because those and other eye diseases are the ones that are preventable. So thinking about prevention and kind of early diagnosis and treatment of eye disease, my main research focus and what I'm interested in is, does getting people to the eye doctor earlier and preventing visual problems, does that reduce the risk of hallucinations and falls and other things, years down the road in Parkinson's? So yeah, a lot of research to be done with vision in Parkinson's, not just in and of itself, but how it relates to other aspects of our health.
Okay, and just check. So we're trying to screen some of these questions, trying to focus mainly on the Parkinson's one. So and vision in Parkinson's. Just see. I don't know if you're able to pull up other ones, but I think. And so just to answer a question, so I believe that the program is being recorded. So there's a question about will it be available, and I believe it. I'm not sure exactly what format, but this will be available after it's over in some form, and MAPS will certainly send that out, I would imagine. And I just perhaps take this opportunity to thank you so much for joining us for this chat this evening. It was great. I learned a lot. I think it's very good to have these sort of nice informal talks and people can ask questions and try to really take some of the mystery out of what happens when you go to the doctor. So thank you so much. I just remind everyone to please send in their surveys when you receive those so we can adjust what we do and make sure that we serve everyone as best we can. Thank the sponsors again, and Dr. Hamedani, thank you so much. Have a good evening, and everyone have a good, safe Tuesday night. All right, bye-bye.